Lecture. We are joined today by Dr. Carter's son, Jay, and daughter-in-law, Bridget. Jay Carter is a physician assistant and assistant professor of neurosurgery at Duke, and his wife, Bridget, is an associate professor and the associate dean for diversity and inclusion at the Duke School of Nursing. I would also like to acknowledge Dr. Carter's widow, Elise Carter, who is unable to attend today, and his stepdaughter, Sonia Wilson, who has joined us today as well. Thank you so much for joining us today. We really appreciate you all. An important part of the Carter Memorial Lecture is the annual Carter Memorial Community Service Award, which was established in honor and memory of Dr. Carter's commitment to community service. This award is sponsored by the Carter Clinic and given to a Duke Psychiatry trainee who has shown a commitment to community service during their time at Duke. The recipients of this year's award are Doctors Rick Walsison, who's a second-year psychiatry resident, and Dr. McCann, a fifth-year med psych resident. Congratulations to Rick and Peter. Thank you so much for your work. Now I would like to introduce Dr. Jenga Harrison to talk more about the James H. Carter Senior Memorial Lecture. Dr. Jenga Harrison received his medical degree from the University of Tennessee College of Medicine in 1997. He was a resident in internal medicine and psychiatry at Duke University Medical Center from 1997 to 2002 and completed the Templeton Foundation Postdoctoral Research Fellowship in Religion and Health at Duke University Medical Center under the fellowship director of Dr. Harold Koenig from 2002 to 2005. Dr. Harrison serves as the medical director of the private child and adult psychiatric practice of the Carter Clinic, where he has served for many years as its leader and is also a consultant to private mental health organizations through Good Samaritan Counseling. Doctors Jenga and Dion Harrison, who I also seen has joined us today, are owners of this organization, which has 10 offices in North Carolina. I want to thank Dr. Harrison for your support, partnership, and leadership, and I turn it over to you.
Thank you, Dr. Ryan. Good morning, everyone. It's always fun for me to come back to Duke annually and see familiar faces. Everybody's a little bit grayer now, but everyone's looking good, no worse for wear. I want to acknowledge my wife, Dr. Dion Harrison. Thank you so much for all that you do, your support, and your active participation with the Carter Clinic, and you're an integral part of our success, as you know. And thank you to Jay Carter and Bridget and the Carter family for all the ways you all have supported us through the years. Very much appreciated. Look forward to bigger and better things. Today I have the opportunity again to bring to memory Dr. James Carter in the Carter Memorial Lecture. Dr. Carter was the first African-American full professor of psychiatry at Duke University Medical Center. Dr. Carter arrived at Duke in 1970. Actually, that's when I was born, and served as a tenured professor for more than 20 years. Throughout his career, he was committed to community psychiatry, particularly in the areas of substance abuse and mental health care for prisoners. Dr. Carter played a critical role in building mental health care services at not one, but several facilities, including Lincoln Community Health Center in Durham, the Alcohol Treatment Center in Raleigh, Johnson County Mental Health Center, and the Department of Corrections. Dr. Carter was a scholar, having written and published many articles and book chapters. He was an educator, having mentored dozens of residents here at Duke. I am one of those residents, and a compassionate clinician. It also gives me great privilege to talk a little bit about our company, the Carter Clinic. As Dr. Ryan said, we have 10 offices. We have recently added a child psychiatrist here from Duke, Dr. Caldwell, as you all remember her. And we have 28 therapists, residential treatment programs, and we recently had a award for whole person integrated care. So now the Carter Clinic is doing some primary care as well. So back to med psych roots. Our distinguished lecturer today for the Carter Lecture is Dr. Ruth Shim, and I will introduce her. Dr. Shim has a master's in public health as well as a doctor of medicine. She is the Luke and Grace Kim Professor in Cultural Psychiatry and Professor of Clinical Psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis. She also serves as Associate Dean of Diversity and Inclusion Education at the University of California, Davis School of Medicine. Dr. Shim received a Master's in Public Health Policy from Rollins School of Public Health at Emory University and a Doctor of Medicine from Emory University Medical School. She is a member of the Board of Trustees at the Robert Wood Johnson Foundation and the American Association for Community Psychiatry. She serves on the Research and Evaluation Committee of California Mental Health Services Oversight and Accountability Commission. Say that 3 times fast. She serves on the editorial board of JAMA, Psychiatric Division, Psychiatric Services, Community Mental Health Journal, and American Psychiatric Publishing, and is co-editor of the book, Social Determinants of Mental Health, and the recently published Social Injustice and Mental Health. She's a former fellow of the Executive Leadership in Academic Medicine program and an at-large member of the National Academy of Sciences, Engineering, and Medicine Forum on Mental Health and Substance Abuse. In 2021, she was a recipient of a National Alliance of the Mentally Ill Exemplary Psychiatrist Award and the UC Davis Health Dean's Award for Excellence in Mentoring. Dr. Shim's research focuses on mental health, disparities, and inequalities. She also provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment Clinic. I bring to you Dr. Shim. I'm very excited to hear her talk today. Welcome, Dr. Shim.
Thank you so much, Dr. Harrison, for that introduction. I just would like to say what a pleasure it is to virtually join you all today. I thank Dr. Rin and everyone at Duke for the invitation. And I also want to give a special thank you to Dr. Carter and the Carter family. It's just an honor to be here to present in his memory and his honor. So today we are going to talk about social justice and mental health. I have a lot of content to cover in an extremely short amount of time, so we're going to launch right in. And we have a couple of things we're going to accomplish in this short period of time. We're going to go over several definitions. I think that definitions are really important. We're going to define concepts such as social justice, social determinants of mental health inequities. We're going to consider how social injustice contributes to mental health inequities. And then we are going to collectively identify 3 solutions to promote equity and justice in mental health. There's another learning objective that we're going to have that is not listed here, which is really about the work in thinking about social injustice and thinking about structural racism. How to do this work and to make advancements in this space, we have to develop a practice of self-reflection. And so throughout the talk, I'm going to offer up some self-reflection questions so that we can all kind of get in the habit of thinking deeply and internally about some of this work, because I do think that is an important skill to develop. I have nothing to disclose. I have no financial relationships to disclose, but I always have to start any talk around social injustice, structural racism, health inequities. I have to start off with a disclaimer. And the disclaimer you'll see is important for a number of reasons. But the disclaimer that I always have to make is that this is a difficult and uncomfortable topic. As we talk about these issues, many complex feelings emerge. Those feelings include things like guilt, anger, resentment, and defensiveness. In fact, as I speak about these things, you may perceive me of accusing you of being a number of horrible things like racist or sexist or any other number of things. You also may feel, as I'm presenting this material, that I have some sort of specific political agenda that I am advancing, or you may feel that I lack any type of objectivity or scientific merit in what I'm sharing. And I bring up all of these things because these are all things that I have been told that I have done when I talk about these issues. And so I want to just kind of lay that out on the table, that because this is such a difficult topic, a lot of times these feelings do emerge, and it's kind of normal, I think, to have some of these feelings. And so we as mental health professionals, if we can't acknowledge that there are difficult emotions that are related to these topics, how can we expect other people to move forward? How can we expect any of us to make any sort of progress in this area? And so why is it so hard to talk about these issues? Why do we have such difficulty? We've been socialized to believe that it is not polite to talk about many of these topics like racism, like injustice and oppression. And in particular, as health professionals, we have not been taught about the connection between oppression and injustice in health. And the other reason why it's so hard to talk about these issues is because we're in the midst right now, following the death of George Floyd and the death of Breonna Taylor, we're in the midst of what many people thought of as a racial reckoning, and increased awareness of racism and an increased awareness of harms against people of color in this country. But unfortunately, the data doesn't necessarily kind of bear out that we are in a racial reckoning. This is data from the New York Times that shows that white people are actually currently less supportive of Black Lives Matter than they were at the beginning of 2020. So what we saw was that there was a huge spike in support for Black Lives Matter following the death of George Floyd. And then as time went on, you saw that spike not only erode, but you saw white people in particular become significantly less supportive of the idea of Black Lives Matter than even prior to George Floyd's death. And so it really just speaks to the general retrenchment, the general difficulties around talking about these issues, around thinking about these concepts, and the general barriers that we have to really making progress in this space. And so the last part of my disclaimer is just to say that when those emotions show up, when we think about all these difficulties, I often like to call on the words of James Baldwin. He said, "I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason." So with that, I think we can launch into the talk. And so first, we need to define some concepts, and the most important one is social justice, and even the concept of social injustice. And I'll just point out, as I said, these are complicated topics. The term social justice is loaded. I think that many people have different ideas about what social justice means. It doesn't always have positive connotations. And to that point, there was an article that was published in the Wall Street Journal, an op-ed in September 2019, written by a physician by the name of Stanley Goldfarb, who was the Associate Dean of Curriculum at the University of Pennsylvania. And he expressed a lot of concern, a lot of, I guess, consternation at the idea that social justice was something that was being infused into medical education. And he felt that this was a very negative direction that medical schools were taking. And what he said was, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? And he also said curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness, and so will many of your doctors in the coming years. So he really sounded the alarm. He said this is a dangerous place, this movement into social justice. But also he had many people disagree with him, including several of his colleagues at the University of Pennsylvania, and they published a response to that op-ed in the Philadelphia Inquirer. And their response was that social justice is the foundation of healthcare and the foundation of medical education. And what they said in this op-ed was that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. So with that, I think, we've highlighted the controversy, but it's really important to be precise with definitions. And so social justice is in fact a philosophical term. One philosopher defined social justice as the distribution of good or advantages and bad or disadvantages in society. And more specifically, how these things should be distributed in society. It's concerned with the ways that resources are allocated to people by social institutions. So the decisions that we make as a society, social justice is really saying it's the decisions that we make as a society as to who is worthy of advantages, who's worthy of goods, and who's worthy of bad and disadvantages in our society, and how we make those decisions. And then another philosopher, John Rawls, said that social justice was really about assuring the protection of equal access to rights, to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. This becomes, I think, so critical when we talk about mental illness, because oftentimes people with mental health problems, particularly people with serious mental illness, people with substance use disorders, they often end up due to oppression, due to not having equal access to these opportunities, they end up being the least advantaged members of our society. So social justice becomes an incredibly critical role when thinking about mental health. So I mentioned we're going to be talking about race, and we have to kind of throw some additional caveats on here, because we're currently in a state where we think a lot about race as it relates to medicine. And there are some challenges in the ways that we use race in our society. Race is a social and a political construct. And I know we've all heard this before, but it's a little bit of a difficult thing to really understand. What it's saying is that the idea, the very development of the concept of race was developed, was constructed based on social and political ideals, or based on the needs to advance certain social or political practices. And so when we say that race is a social or a political construct, it means that it cannot be accurately biologically or genetically categorized, meaning that we cannot draw somebody's blood and determine what their race is. And we actually cannot run a genetic test on someone and determine what their race is, despite many geneticists, some mistakenly believing that. So it is not a biological process. It is not a biological construct. It is not a genetic construct. It is a social and a political construct. What we do know about race is that it is a very rough and imprecise proxy for a number of things, including culture, genetics, socioeconomic status, many other things. I find it very interesting that in medicine, a field in which we really try to be as precise as possible, that we rely so heavily on such a rough and imprecise proxy for many other things, instead of measuring the thing that we are actually trying to understand. And I will also say that we often use race to confirm a number of our assumptions, our prejudices, and our biases about our patients, about other people. But particularly in medicine, we use race to confirm these assumptions, rather than using race or thinking about race as the construct that it is, the social and political construct that it is. And I just want to pause here and just note that when I say that race is a social and a political construct and not a biological one, I'm not saying that it is not incredibly important. Just because it is socially and politically constructed doesn't mean it doesn't have sweeping and significant implications in our society. So when I say that it is not a biological or a genetic construct, does not mean that it is not significant and majorly important. Here's, I think, a very challenging quote that I would like us to contemplate for just a second. It is, African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less healthcare, more disease, and lower life expectancy than whites. If you believe Blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, Institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans. The reason that it's so important to think about this particular quote is that, again, we're all very well-meaning people, and I'm not believing that anybody is actively racist. I do think, however, that sometimes we err on the side when we are faced with all of these inequities and seeing all of these differences in outcomes between populations. Instead of defaulting to the decision, the understanding of how institutional racism provides this traceable explanation, we sometimes default into thinking that maybe there is some sort of natural biological difference, some sort of natural thing that distinguishes these populations and leads to these different outcomes that we see, rather than understand how significant institutional racism is for the explanation of the inferior societal position of African Americans. Okay, so I think let's take a little history tour so we can have a better understanding of how we got to where we are. And this is a painting that I think is quite famous, the Signers of the Declaration of Independence. And, you know, it is really thinking about the foundations of our society and what this particular country was founded on. We know very well the words that came from the Declaration. We hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. These are such significant words to us in thinking about the founding of this country. But I think it is really important that we have to note and we have to understand that when the signers of the Declaration gathered together to uphold this document, they were very specifically talking about the rights of life, liberty, and the pursuit of happiness for a very specific group of people. And the people they were referring to were the people that you see here in this room. And they really were deeply convicted in the belief that people that looked like them should have the rights to life, liberty, and the pursuit of happiness, but not particularly for anybody else. And then constructed a society kind of built on that fundamental assumption. That certain populations are worthy of the rights to life, liberty, and the pursuit of happiness, and other populations, it's not so much of a given. And then about 80 years later, we moved in the future to a physician by the name of Samuel Cartwright. And Samuel Cartwright was somebody who spent a lot of time studying the behavior and the beliefs of the behavior and the actions of enslaved Black people. And in that time that he spent kind of examining enslaved Black people, he developed some descriptions of illnesses that he said were unique mental illnesses that were specifically unique to Black people. One of them was a condition he described as drapetomania. He said this was the mental illness of an enslaved Black person trying to escape slavery, trying to escape their captivity. And he described this as a mental illness. He said, if any one or more of them at any time are inclined to raise their heads to a level with their master or overseer, humanity and their own good requires that they should be punished until they fall into that submissive state which was intended for them to occupy. They have only to be kept in that state and treated like children to prevent and cure them from running away. He also described another condition by the name of dysesthesia ethiopica. He said that this was the disease of rascality, or the natural tendency of enslaved Black people to be lazy, to not want to work very hard. And he said that this mental illness, this disease, is the natural offspring of Negro liberty, the liberty to be idle, to wallow in filth, and to indulge in improper food and drinks. After the prescribed course of treatment, the slave will look grateful and thankful to the white man whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. And I think, you know, why do I bring up these kind of bizarre, old, clearly false thoughts about certain mental illnesses in certain populations? I think it's important because we can look at this information, we can look at this historical context and say, we've come so far and we don't think this way. But many of these ideas are remarkably persistent, not only in our society today, but also in the ways that we look and interpret behavior, in the ways that we diagnose and treat certain mental health conditions now. And definitely the idea that Black people are lazy or they don't want to work hard, despite the evidence of enslaved Black people working in incredibly difficult conditions with levels of productivity that were kind of superhuman and beyond the level that a normal human being should be expected to work at, often with no nutrition, with limited care for themselves. There is a very specific it very specifically doesn't make sense that there would be a description of a disease like this. And yet, very persistent is the belief that Black people don't work hard and are lazy. And that is a very common belief that is even held to this day. So these awful kind of pseudoscientific theories are remarkably persistent and enduring in our society. I want to take a minute to define the concept of health disparities and contrast that with the definition of health inequities. So health disparities are defined as differences in health status among distinct segments of the population, including differences that occur by gender, race, or ethnicity, education or income, disability, or where you live. And we can contrast that with the definition of health inequities, which are differences in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. It's really important to contrast these because they're not so different in their definitions, but the difference that we can see clearly is that while health disparities describes an illness, describes a difference in health, it says nothing about what the cause of that difference is. Whereas health inequity specifically is saying that the cause of that difference is systemic, avoidable, and unjust social and economic policies and practices. And the problem is if you don't name that cause, if you don't specifically point to these systemic, avoidable, and unjust social and economic policies and practices, we tend to always default to thinking that that problem, that difference is the result of some sort of intrinsic difference between populations. That maybe if there's a difference between men and women in terms of rates of depression, that it must be some sort of hormonal difference and not the difference related to unjust social and economic policies and practices like patriarchal systems in our society. That we default to looking at and seeding the pathology in the individual or in the individual population group instead of looking at the structural external forces that are working to create those inequities and outcomes. And oftentimes I think what's interesting about health inequities is that 98% of the time, the differences in health that we see are the result of these systemic and avoidable and unjust practices, and not because of some sort of intrinsic difference between any population that we're looking at. The other point that's interesting about these two concepts is that in other countries, the term health inequities is really the commonplace term that is used. But here in the United States, when we talk about differences in health, we really spend most of our time using the term health disparities. Okay, so I mentioned that I'm gonna challenge people to self-reflect, to get into that practice about thinking about how the work that we're talking about impacts you personally. And so here is my first self-reflection question for you all. When thinking about differences in mental health outcomes among different racial and ethnic population groups, are we, or am I thinking about mental health disparities, or am I thinking about mental health inequities? So something to ponder a little bit. Okay, so another definition, this one is the social determinants of mental health. These are the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And the social determinants of health are prominently responsible for the health disparities and inequities we see both within and among populations. So I want to take a minute to kind of walk you all through my path, my thought process, and thinking about the relationship between the social determinants of mental health and then social injustice in mental health. And to do that, we have this very busy figure that I'm going to walk us through really quickly. So at the top of this figure, you see adverse mental health outcomes and mental health inequities. And each time you move down the figure, you are moving further upstream. So what we know about illness is that a risk factor is defined as something that precedes a disease or an illness and increases the likelihood that somebody might develop that illness. So as we move one step upstream, we get to this level where we see a number of risk factors, and they include things like poor choices and reduced options, behavioral risk factors, physiologic stress responses, and psychological stress. In psychiatry and mental health, we spend a lot of time trying to intervene at the risk factor to prevent a disease, to prevent a negative outcome. And so we do a lot of risk assessments, we do a lot of evaluations, and we do a lot of interventions targeted at reducing risk factors. What I've come to understand in thinking about the social determinants of mental health is that if you are intervening at the level of the risk factor, you are intervening too late, because there is a context, as Lincoln Phelan described, the fundamental causes of disease, or as Jeffrey Rose and Sir Michael Marmot describe, the causes of the causes. There is this context that develops prior to the development of the risk factor. That context is the social determinants that are the social determinants of mental health. And so all of those things, those social determinants, set the foundation for the development of the risk factor. And so those are the things like adverse early life experiences and discrimination and low education and unemployment and poverty and homelessness and food insecurity and neighborhood disorder and climate change, that all of these things lead to the development of the risk factor. But as I have spent more and more time thinking about these concepts, I've come to understand that if you're intervening at the level of the social determinant, you are still intervening too late, because there is an underlying context that is driving the creation of those social determinants of mental health. And that underlying context is unfair and unjust distribution of opportunity, which is in fact social injustice. And the thing driving that social injustice are two very fundamental things: social norms, or the ideas that we have about people in our society, who we decide in our society is worthy of advantage and who we decide is worthy of disadvantage. And then the public policies or the laws that we pass, the decisions that we make, the policies that we enact that reflect those social norms. Those things come together to create unfair and unjust distribution of opportunity, which drive the social determinants of mental health, which lead to a number of risk factors, which then lead to the mental health outcomes that are poor and the mental health inequities. So just to take a second to kind of go through an example of that, we can think of this as it relates to crack cocaine. And particularly, we have a number of powerful social norms around the type of person who uses crack cocaine. And particularly when we think in this country, because of the media and because of news and all of these things, we think about who uses crack cocaine. We often think of Black people. We often think of African Americans. And we have gendered beliefs about how Black people use crack cocaine. For example, if you're a Black woman, we think of you as a terrible mother who puts the needs of your your personal needs and wanting to get more drug ahead of the needs of your children. If you're a Black man who uses crack cocaine, we think of you as dangerous, as violent, as somebody who will harm other people. And so because we have these particularly powerful social norms, we pass laws that reflect that belief system. And so one of the laws that we passed in 1986 that reflects this belief system is the Anti-Drug Abuse Act. And this was the law that created a 100-to-1 jail sentencing disparity between crack cocaine and powder cocaine. And so what that jail sentencing disparity did is it said that if you had 1 gram of crack cocaine in your possession, you would get the same jail sentence as somebody who had 100 grams of powder cocaine in their possession, an equal sentence for those things. When clearly one is for personal use and one is for intent to sell, it didn't matter, the punishment was the same. And this is very bizarre considering how these are the same drug, that these are the same chemical compound. So there is no difference in these drugs, and yet there was a specific huge difference in the criminalization of these drugs, and particularly related to who uses these drugs. So those policies then had sweeping implications for outcomes, because they led to unfair distribution of opportunity between people who use crack and people who use powder cocaine. And that led to a number of social determinants, including incarceration, which led to arrests, which once you get out of jail, you are more likely to be in poverty. You have more challenges getting employment. You have difficulty getting access to healthcare. A number of social determinants are activated with incarceration. And then it's even intergenerational or transgenerational, because one of the adverse childhood experiences is having a parent that is incarcerated. And so this is a sweeping implication due to a policy or a belief system. And I also want to say, let's contrast that with the idea of the ways that we think about the opioid epidemic, because when we think about the opioid epidemic, we don't consider it to be a criminal justice system. We created different policies. So we had different beliefs about the type of people who use opioids, and then we created different policies to address the opioid epidemic, to address this. We see it as a public health crisis, not a criminal justice crisis. And so the implications and the impact on the social determinants of mental health are different as a result of that. Okay, so a couple of concepts. Here are some things that's important to know when thinking about social injustice. One is this concept called essentialism. This is the belief that there are distinct, unchanging, and natural characteristics that define social groups. It is the idea that we can put human beings into perfect categories, that we can put people into clear categories by race or ethnicity, by gender, or even by sexuality that facilitate their categorization. The truth of the matter is humans are much more complex than this. And in all of these, we cannot essentialize. We cannot put people into such rigid boxes of categorization for any of these concepts. Erasure of context is when we fail to consider the socio-historical context when seeking to understand the etiology of inequities. The best example of that is clearly thinking about Drapetomania and Samuel Cartwright's belief system. The idea that someone would want to run away from slavery would be mentally ill is a clear understanding of not understanding the context by which you're making these determinations. Biological determinism is the false belief that racial groups are biologically and genetically different. And I really struggle with how in 2022, I have to kind of highlight that this is a false belief that is, I think, still very strongly held by a lot of healthcare providers, that there are biologic and genetic differences between races. There was a recent study that was done looking at medical students and residents' beliefs about differences between Black and white people, and found that that medical students were more likely to believe that Black people had thicker skin than white people, or that Black people had fewer nerve endings than white people. And then cultural determinism is kind of like the cousin of biological determinism. It is the false belief that the differences that we see in populations and in racial groups are primarily the result of cultural factors, that they have to do with choices that certain cultural groups make. And it really has this idea that certain cultures are just making better decisions, particularly when you think about things like diet, that like some cultures make good and healthy choices and other cultures make less so. Again, without understanding the context behind why certain cultures have certain traditions that they have in their lives. So another self-reflection question: what were the theories of biological and cultural determinism that I was taught in my medical and psychiatric education and training? And I think we all, when we really like dig into this self-reflection question, I think we all can come up with some examples of this. Another really important concept is one of oppression. And so this is work of Iris Marion Young, where she talks about the 5 faces of oppression. So the first she describes is exploitation, which is the unequal exchange of one group's labor and energies for another group's advantage and advancement. And of course, when we think about slavery, that is a clear example of exploitation, but we have lots of examples in modern day times, including human trafficking, but also even treatment of warehouse and migrant farm workers in our current society. Cultural imperialism is when we establish the ruling class culture as the norm, and we other all those groups that are not part of the dominant culture. So we decide that certain populations and certain groups should be compared to the ruling class culture. A perfect example of this in research involves the ways in which we often, when thinking about reference groups, when looking at differences according to race, when looking at odds ratios, for example, in research, I've never seen a study in which, no matter how many people of whatever race are in that study, that the reference group was not white people. Always the reference group is white people. And it's sort of a default that, of course, we would compare whatever group we're looking at to white people. Powerlessness is when oppressed groups lack power and are blocked from routes to gaining power. And clearly we see examples of powerlessness currently in thinking about voter suppression and preventing certain people from having adequate representation of themselves in policy arenas and in government. Marginalization is when we expel specific groups from meaningful participation in society. Examples of marginalization include historical examples like Japanese internment, or many kind of current modern day examples, treatment of indigenous populations and mass incarceration. And then finally, violence are threats or experiences of physical and structural violence, which I think is self-explanatory, except for the fact that I'll define structural violence as when someone who has populations that have power commit harms against populations with less power, and it doesn't have to be physical harm. Okay, so another definition for you is structural racism. It is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequities. This system identifies dimensions of our culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. It is not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, political, and economic systems in which we all exist. And it does not require the actions or intentions of others. So what that means is that if we got rid of all of the interpersonal discrimination, the interpersonal racism that exists in our society today between one person and another person, we would still see racial and ethnic inequities in all of these structures and factors due to the persistence of structural racism. So a couple of examples of how we see structural racism showing up in mental health. I already described crack cocaine and the war on drugs. Residential segregation and redlining has led to significant differences in certain neighborhoods in terms of where people access healthcare services, where people access clinics, how difficult it is to get to a nearest clinic, and particularly when we think about mental health, access to mental health clinics, access to hospitals, access to outpatient care is often deeply impacted by residential segregation. Immigration policy, this has a lot to do with which countries we think it's appropriate for people to immigrate to the United States from, and specific policies. Certain countries that we border, we don't have walls that we build, and other countries we do. But in addition to this, the other issue we see with immigration policy is that we create quotas to prevent certain people with certain illnesses from entering into the United States. And so there are significant quotas around people with serious mental illness, around people with substance use disorders. And because of that, those folks are often, people with serious mental health problems are screened out from consideration from being able to immigrate into the United States. And so we do this on so many conditions that people talk about this healthy immigrant effect, and they say, oh, this particular population coming into the United States is generally healthier. It must be, again, it must be a cultural deterministic frame. This particular population must make better cultural choices about their diet, their exercise, and the ways they deal with stress, without understanding that our fundamental policies have created a system that screens out and prevents less healthy people from coming into countries as immigrants. And so the population that we're comparing, the immigrant population to our native-born folks in the United States, there's more variation in terms of health in that population. The Social Security Act of 1935 was the act that created retirement benefits, a really helpful act that allowed older people to be able to retire, to be able to kind of not have any sort of financial strain as they got older, and that they could pass their wealth on to their children and their grandchildren. The reason that this really wonderful act is an example of structural racism relates to the fact that in order to get this act passed, a deal had to be struck with Southern senators that said that it would exclude domestic and agricultural workers. And in those times, the majority of domestic and agricultural workers were Black people. And so they were not able to participate, even though they worked for their lives like all other Americans. They were not able to participate in paying into the Social Security Act and getting those retirement benefits upon reaching retirement age. And so what that meant is that an entire generation of Black people were not able to pass wealth on to their children, their grandchildren. They were not able to live in financial security after they reached retirement age. And that was really the start of the really massive wealth gap that we see in our society today. And finally, mental health care. This is data from SAMHSA that said in 2018 that 69% of Black adults and 67% of Latinx adults with any mental illness received no treatment, whereas 42% and 44% of Black and Latinx adults with serious mental illness received no treatment whatsoever. And then when we look at substance use disorders, 89% of Latinx adults and 88% of Black adults with substance use disorders reported receiving no treatment for their substance use conditions. What's so interesting about this is that when we stop and we think, well, what is really causing, what's driving these differences that we see, we can tend to kind of default back to saying things like, oh, maybe Black and Latinx people have more stigma. Just culturally, maybe they tend to, be less open to receiving mental health services because of stigma, or maybe Black and Latinx people culturally as a group have less insight into the fact that they have mental health problems. These are some of the general ways that we use to explain these differences. But when asked, patients said that cost was the most commonly cited reason that they were not seeking care. And this was twice as often as minimizing symptoms, nearly 5 times as often as stigma. So again, a structural explanation for the differences that we see instead of a kind of an internal or personal explanation. So in the time that we have left, I think we need to talk about where we need to go. So we're currently in a state of inequality, that's unequal access to opportunities. And many people think that where we need to go is we need to get to a state of equality. And this is when we evenly distribute tools and assistance to other people. Equality is really focused on fairness. It says that whatever we do for one population, we need to do for every population. And it's very much focused on, we have to make sure that we're fair and we're equitable in everything that we do. But as you can see with this figure, equality doesn't get us to where we need to go. And so what we have to focus on is equity. And equity is when we customize the tools that identify and address inequity. So we actually have to give people the things that they need, the population, the specific interventions that they need to be successful. And those interventions will be different for different populations. And equity isn't focused on fairness. It's really focused on how do we move forward. But we can't just be focused on equity. We actually have to partner that with justice. And justice is when we fix the system to offer equal access to both tools and opportunities. So justice is really about reforming the system, changing those structural barriers in the place. And so we need to partner justice with equity. And so how do we go about doing that? We have a number of ways to think about this, and I'll walk us through that as quick as possible. The first is education and self-reflection. So we've been practicing self-reflection, and here is a number of books and resources that can help increase people's education on these topics. So I highly recommend these books if someone wants to increase their knowledge. And honestly, it is the first and most fundamental step to getting to where we need to be, is increasing your knowledge. These are not things that we're taught in any of our formal education. And so we have to actually seek this knowledge out, this understanding. I also give this list of resources because I often say, we're all very busy people. We don't have time. Some of those books are dense. These books are easier to read. And these are podcasts and documentaries that can start you on this journey that are a little bit easier and maybe a less of a time commitment. Another self-reflection is, how much time have I committed to learning additional information about these topics, especially considering that they're not taught traditionally in educational settings. And so then the next thing that we have to do is start practicing this concept of cultural humility, which is work by Melanie Turvalon and my colleague and friend, Jan-Marie Garcia. The two of them thought about cultural humility as committing to a lifelong process of self-evaluation and self-critique, and desiring to fix power imbalances between providers and clients, and also developing community partnerships and to advocate within the larger groups in which we participate. So a key among thinking about cultural humility is this idea that you can't take one class and become competent or know what you're doing in this space, that we are always learning and growing, and this is a lifelong commitment that we have to make. And we have to couple cultural humility with this concept of structural competence, which is the trained ability to discern how a host of issues defined as symptoms, clinical problems, attitudes, or diseases are influenced by upstream social determinants of health. And so how, when we're looking at the patient in front of us, can we see how all of those structural factors that we've been talking about come to play in the patient that we're seeing sitting in front of us? But fundamentally, if we want to alter these things, we have to think about public policies and social norms. And so we have to promote social norms of inclusion and equity and respect. And we do that by enforcing social norms of inclusion and equity, educating or legislating to change social norms. That means either helping people understand and grow when they violate certain social norms, or using the existing laws and policies that we have to keep those people from doing harm to others. Observing and challenging our own biases and norms. And evaluating and breaking down any unnecessary hierarchies. And I'm very specific about, there are some hierarchies in our society that are very necessary, and those need to exist. But many of our hierarchies in society are just there to make people understand their place in society, their role, and those are not necessary to persist. And if we're going to advocate for equitable public policies, this involves moving beyond the walls of our clinics, our hospitals, and our treatment centers, advocating policies that address the social determinants of mental health, and all policies are mental health policies and health policies, and communicating with our elected officials and promoting equitable representation, and advocating by centering and elevating those people that have lived experience and have that expertise. And so I will end by saying, I started this talk by saying that this wasn't a political talk, even though you might accuse me of, and I will say I'm going to throw in one tiny little political statement here, which is that policy stances and policy interventions are required. Because if you are to remain apolitical or neutral, that is in fact a political stance. It's a tacit acceptance of the status quo. And so the last thing we have to do is get into the habit of speaking up and taking a stand. And so I really rely on the words of Audre Lorde. She said, when we speak, we are afraid our words will not be heard nor welcomed, but when we are silent, we are still afraid. So it is better to speak. And before I end, I just want to make one final comment, which is that, this was not the most uplifting conversation that we had, but I do want to acknowledge that in this work, we have made so much progress. And progress is made through the passage of legislation, through court rulings, through other formal mechanisms that aim to promote racial equality. But we have to acknowledge that with progress, always comes retrenchment. And retrenchment refers to the many ways in which progress is often challenged, neutralized, or undermined in key policy arenas. If you're not prepared for the retrenchment that comes with progress, you can start to despair, you can start to feel overwhelmed and feel like you're not making any progress in this area. So and as an antidote to that despair and to hold us, I leave you all with the words of Congressperson John Lewis. And he said, "Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." Thank you.
Thank you, Dr. Shim. Excellent presentation. And there's lots of thank yous in the chat box. Beautiful presentation, standing ovation. So thank you, thank you. And thank you particularly for that last slide. I think we needed that. It's really, you can really lose sight, and because it can be very despairing. So really can't thank you enough. You're doing great work. I'm just checking here. As I'm looking for one question I did get, but I did want to ask you one thing. Anything in specific you can say specifically about the field of psychiatry and the struggles that we have, particularly with access? And I think some of our challenges is that there's restrictions in terms of insurance coverage, and then there's a good part of our field that resides in the fee-for-service area, so it just makes it really hard to approach a broader population approach. And how sort of the more structured, organized medical organizations, I think, may support some of this too, that makes it hard to change. So just any thoughts you have about that?
Yeah, I mean, I think that what you're describing, like you can clearly trace our current healthcare system, which is unfortunately a really poorly designed system that doesn't serve people well. And when you think about all the other countries in the world and how they've managed to create systems of healthcare that manage to serve populations, our system is very directly tied, and you can trace it back very clearly to structural racism as the reason for why we have the healthcare system that we have in this country. And so, you know, the 1619 podcast does a really good job of kind of drawing the connections, and particularly the role of the AMA, the role that many physicians, that many psychiatrists have played in advancing these policies that have led to this really broken system. And I often point out, you know, so we see this in the healthcare system writ large, but then it manifests, again, because it is a social justice issue, and because people with mental illnesses are the least advantaged members of our society. You then see that the mental health care system is extremely poorly designed and leads to extreme poor access. And again, it relates to what are our beliefs about people with mental illness, and what are the laws and the policies that we have created as a society around how to care for those people, and why have we found it totally acceptable to construct a mental health care system that does not serve the majority of people, and what is our role, I think, as providers in being complicit in that system. And so it affects everybody. But yet it was put in place as a way to oppress particular populations, and it has led to harm for all of us. And we have all kind of, I think, suffered being part of that system. So I don't know if I have answers as much as
I think it's well said, and and I agree.
Yeah.
And I think there's also which doesn't really get talked a lot about or written about, is just the treatment of different types of providers and what your value is. So if you work in the behavioral health sector field or pediatrics, or just the sense of those providers and what they're worth, what their value of their work is.
Absolutely.
I think it's
a really important
hidden issue.
Absolutely.
Yeah, no, thank you. Another comment was just, and this is kind of a weighty one, so we've only got like a minute and a half, but this issue around the Department of Justice using AI algorithms to determine a number of things, some of it supposedly for prevention of crime or determining who might get an early release. And sort of the biases and the unfairness that can come out of using those kinds of tools. If you have any thoughts about that, that was one question.
That is a weighty one. I think that we have enough evidence to support that algorithms. There's a great study that shows that many of the algorithms that we use are racially biased, and of course they are, because they are created by humans, and humans are racially biased. So I think generally our use of I think we cannot look to algorithms, we can't look to AI as ways to help us through this situation, because these things are inherently structurally, they are part of the structurally racist system. And then you take that on into overdrive, and I could speak on this for a long time in thinking about the ways in which it's applied within the criminal justice system, which I don't think is worse than any other system, but yet I think does a better job of illustrating the flaws of how structural racism invades our systems. And I think we can see it almost even more clearly in the criminal justice system than we can, say, for instance, in the healthcare system, which is also, just as structurally racist, but it's maybe a little bit more concealed. So absolutely, I think algorithms and using computers is unfortunately not going to save us, and we have to be really thoughtful about that.
Yeah, no, thank you for your thoughtful answer on that. But unfortunately, we are out of time. You've done a phenomenal presentation. You have really educated us. Can't thank you enough for your leadership and all the great work that you're doing. Sorry it wasn't in person, but like we talked earlier, we'll hope to get you back here, real soon, but when we do it in person. So continue the great work. Really appreciate you. And thank you. Thank you, everyone else. Thank you to the Carter family. Thank you, Dr. Harrisons, both Harrisons. Thank you so much. Everyone have a great rest of your week.